Over to you, Dr. Srinivasulu.
Yeah.
Please start.
Good evening, all. I welcome you all to this next ISA, College of ISA and WFSA Presidential Theme Webinar. The theme is Think Globally and Act Locally. And to start, I welcome our Chancellor and President of ISA National, Dr. Naveen Malhotra, sir, and our Vice Chancellor, Dr. J. Bala Subramanian, sir, is also immediate past president and academic chair, and our Pro Chancellor, Dr. A. L. Meenakshi Sundaram, sir, and our Administrative Secretary, Rajiv Gupta, sir, is also Honorary Secretary of ISA National. And I also welcome our Vice President, Dr. Radhakrishna Rao, sir, Vice President, and all the GC members, past presidents of ISA National, all the past GC members, and all the esteemed members of ISA to this. And I request our Dean of Academic Wing of ISA National College of ISA, Dr. Umameshwara sir, to speak few words. Dr. Uma sir?
Yeah. Am I audible?
Yeah. Yes, sir, you are audible.
Yeah. Good evening, Dr. Naveen Malhotra, Dr. Bala Venkat, all the faculty, and the participants in today's webinar. Welcome to the WFSA webinar on Think Globally and Act Locally. Anesthesia has made tremendous progress over the last 20 years. It has extended its activities into various areas like pain management, intensive care, emergency department, palliative care, etc. But one question we should ask at this juncture is, has the progress been uniform throughout the length and breadth of the practice of anesthesia all over the world? Let's take for example, the anesthetic mortality. In advanced countries, it is 1 in 1 lakh to 1 in 2 lakhs. It is countries. While we need to achieve the global standards, we need to keep in mind the limitations to achieve that standard. So, similarly, the availability of adequate manpower, equipment, training, etc. While we aim to achieve global targets in various areas, we have to keep in mind the limitations in the individual countries. So we need to find out local solutions to achieve the targets. So today we have a very illuminated faculty to discuss these issues. So let's listen to them. Thank you.
Thank you, sir. Let's go start the program. The coordinator for today's webinar is Dr. Vibhavari Naik. It's my pleasure to introduce her. She is also moderating these sessions along with Dr. Rajiv Gupta, sir. So to start with, let me introduce Dr. Rajiv Gupta, sir. He is Senior Consultant and Head of the Department of Anaesthesiology and Pain Medicine at Maharaja Agrasen Hospital, Punjabi Bagh, New Delhi. And he is our Honorary Secretary, ISA National, and also Administrative Secretary of College of ISA. He is past Governing Council member of ISA National and past Secretary of ISA Delhi. And he is faculty to many national and international conferences. Welcome, sir. And Dr. Vibhavari Naik, she is coordinator and she is also moderating this session. She is a senior consultant onco-anesthesiologist at Baswa Tarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. And she is clinical lead of WFSA annual theme 2026, anesthesiology along the patient pathway. She is Vice President of IAVST, that is Indian Association of Vital Anesthesia Stimulation. She is Post Secretary of Asia Society Anaesthesiologist and Indian Medical Advisory Council member, Smile Train India. She is Executive Committee member of SOAPC and Honorary Fellowship. She has Honorary Fellowship of IAPA and SOAPC. Welcome, madam. And over to you, Dr. Vibhavari Nayak and Rajiv Gupta for next proceedings.
Thank you for the welcome, sir. I would request Dr. Rajiv Gupta, sir, say a few lines before I could take over the proceedings.
Thank you, Dr. Vibhavari. Good evening, Dr. Naveen, Dr. Bala Venkat, all the governing council members, esteemed faculty members and panelists, and all the members present here in this webinar. So, moving to the theme of WFSA, anesthesiology along the patient pathway. So, it is not a simple thing, but anesthesiologists, they are moving not only away from the, we cannot say away from the theater, but they are expanding their horizon, right from operation theater to the perioperative physicians. They are now critical care experts in emergency medicine, and they are also doing critical care and so many things they are involved in. So the horizon is now increasing and it's in line with the WFSA theme. So now the thing is how WFSA theme can be worked in India. So let me tell you, this theme is not dependent on expensive technology. It is primarily about organization, standardization of protocols and techniques, and basically it's a teamwork. So even hospitals with limited resources can make substantial improvement in patients' outcome by optimizing the care at every stage. Starting from the standardized pathways like developing simple evidence-based protocols, common principles like, in preoperative assessment checklists or difficult airway algorithms that usually we are following. Not that we are not doing it, but to be comprehensively at every stage, whether it is preoperative, intraoperative, or postoperative, we have to be very, very meticulous about what we are doing. We have to be very, very observant about what is happening around. Not only monitors, they help us. We have to be clinically also see that what monitors are telling is corroborating with the clinical things or not. So even in in preoperative patient checkup, not that very costly investigations are required. Simply screening of anemia or uncontrolled diabetes, blood pressure, all these things, we can optimize before surgery. So basic things we can do even in the resource limited setup. But in that case, you have to follow certain things which are like WHO surgical safety checklist, your anesthesia machine, difficult airway card, and like once the surgery is over, proper handover of the patient to the post-operative person who is handling the post-op area. So that is how we can work together and take the anesthesiology to further heights. Thank you.
Thank you so much. And a very warm welcome to everyone who's logged in, our dignitaries, the panelists who joined in. And as we begin the session, I would want you to get introduced to all the stellar faculty that we have on board today. And I'm going to begin with Dr. Naveen Malhotra, sir. Sir, we know, is the president of Indian Society of Anesthesiologists. He's the chancellor of College of ISA. He's also holding president position at the Research Society of Anesthesiology, and he is the president-elect for Indian Society of Study of Pain. He is a member of the WFSA Council and chair of the Asian Australasian Regional Section of WFSA. and a part of WFSA Pain Management Committee. Sir, I would want you to address us and try and tell us what this WFSA theme means for the Indian anesthesiologists. Over to you, sir.
Thank you, Dr. Vibhavi Naik and Dr. Rajiv Gupta for those kind words. Dr. Vibhavi, you will correct me. It's anesthesiology along the patient pathway. Yes. Now that means anesthesiologists should be present at every step from admission to discharge and beyond. When I first came to know about this theme a few months ago, so I introspected what's happening in India, because that's the theme also. Think globally and act locally. In India, as we all know, that there are three types of setups: medical colleges, corporate setups, and freelance anesthesiologists. So I got the answer that in medical colleges, which are producing the young postgraduates, there is a well-structured pre-anesthetic checkup. There is a good intraoperative care, and if some major surgery is there or some event happens, patient goes to ICU. Till that time, things are really very, very good. But if we talk of beyond that, thank you very much for muting yourself. If we go beyond that, we are working in a setup where we are conducting anesthesia 6 days a week. And post-op rounds in the wards, acute pain services are still not well established in all the institutes. Here I'm talking about government and private medical colleges. And this particular aspect is there in some corporate hospitals. But if I talk of freelance anesthesiologist, I think there's a big gap because patients are seen just few hours before the surgery. And when the surgery is about to be over, there is so much of demand that they have to go to other hospitals. If I talk of beyond surgery also, that pain clinics, ICUs, labor anesthesia, trauma care, and resuscitation. Definitely, we have taken giant strides in resuscitation over last couple of decades. Pain also has taken up a big leap, and critical care also, there are dedicated critical care physicians. Trauma also is picking up. So I'm happy also, but there are challenges also because India is a very, very vast country. And as president of ISA National, and all of you will agree with me that every last patient in the remote district deserves a safe anesthesia first and foremost, and also a good anesthesiologic coverage along his patient pathway from preoperative period to discharge and even beyond. The theme is very apt. They have termed it as anesthesiology along the patient pathway, not anesthesiologist along the patient pathway. A single person cannot do all those things because somebody has to take responsibility of preoperative evaluation, anesthesia planning, and conducting intraoperative anesthesia. Another team has to take care of acute pain services and postoperative care. Somebody has to take care of the critical care part of the patients who go into the ICU, and somebody has to take care of the chronic post-surgical pain and labor anesthesia and trauma pain services. So I have got mixed thoughts that we are giving good quality services, but that needs to be expanded uniformly across length and breadth of the country. These are my initial thoughts. Thank you very much.
Thank you, sir. Thank you for sharing your thoughts and setting the context for this webinar. I have a few announcements to make before I proceed. The first one is I would request everyone to mute themselves so that there's no disturbance for the speakers. The second thing that I wanted to say is that if you have any questions for our panelists, you could put them in the chat box. Apologies that we may not be able to allow the attendees to ask the questions directly. From the chat box, either Dr. Rajiv Gupta sir or myself would be taking them up and posing it to the respective panelists. So thank you so much for your cooperation and consideration. And with this, we move ahead to welcome Dr. J. Balavenkat Subramaniam, sir. Good evening, sir. A very warm welcome, and we are indeed privileged to have you here. Sir, as we know, is the president-elect of World Federation Society of Anaesthesiologists. He's also the immediate past president of ISA and vice chancellor of College of ISA. Sir is also the immediate past president of Asia Oceanic Society of Regional Anesthesia and Pain Medicine, and being the founder president of Wfsa, as well as founder chairman of Anesthesia Patient Safety Forum, India. Welcome, sir. Thank you for your time. We know you've been traveling, you've been very busy. You keep moving into global circles and meet global anesthesiologists. You are a part of Wfsa, and we need to hear from you, what is the Wfsa's vision for global anesthesiologists behind this presidential theme? So over to you, sir.
Thank you so much, Dr. Vibha. I'm very glad that the presidential theme for this year is anesthesiology along the patient pathway. And I'm so happy that the clinical lead for the entire globe is from India. So I would begin my small brief session by thanking Dr. Vibhavari Naik for accepting this global position. I think this is the first ever time an Indian has the opportunity to lead the global clinical lead for the presidential theme. Our heartiest congratulations on behalf of the College of Indian Society of Anesthesiologists and on behalf of Indian Society of Anesthesiology. Thanks for taking up this responsibility. And also, I am extremely thankful to Dr. Naveen for giving his perspectives on what India looks at and what India is going to do, the pathway that we are going to take for this particular theme. Thanks to Honorary Secretary Dr. Rajiv Gupta for giving those introduction, and the Dean and the Associate Dean, Dr. Maheshwar Rao and Dr. Srinivasalu. Every president has a prerogative, and Dr. Carolina Haylock Lure from Honduras, the second consecutive women president of the World Federation of Societies of Anesthesiologists, thought it's prudent to choose a topic that will put anesthesia and anesthesiology and anesthesiologist in the forefront of the clinical work and inside an institution. So inside an institution. So she chose this theme. And I'm very happy that currently the World Federation of Societies of Anesthesiologists is the largest global network of the anesthesiologists around the world, close to 6 million anesthesiologists, with 149 members spread over 156 countries for the current members. The challenges are extremely different from each country, and it has been the vision of WFSA to make sure that we embark on capacity building of anesthesiologists throughout the world. There are countries which are extremely fortunate to have excellent perioperative systems, but there are countries where the anesthesiologist is the only sole physician who has no other option but to get involved in prehabilitation, preoperative assessment and optimization, intraoperative care and postoperative care. By choice, several of them can do perioperative care, but by dictum, by the reasons of limited resources, several countries have only one physician to look after the patient in the entire perioperative period. And hence, I think it is prudent that this topic has been chosen as the presidential theme for the 2 years from 2026 to 2028. And it also involves not only to enhance the outcome and decrease the perioperative morbidity and possible mortality by capacity building of the anesthesiologist, but also to put anesthesiology in a leadership position inside institutions, inside countries. They have to be heard. So I think the only way to create visibility for this specialization is to embark on the journey of perioperative care, where the patient has got that the visibility that he gets to know the anesthesiologist, which I think the message today for all of us who are involved in perioperative care or in anesthesia care is to become perioperative physicians. And I want to personally quote that in my institution where I've been working for the last 3 decades, the last 24 years, anesthesiologists have served as perioperative physicians, right from pre-op, intra-op, post-op, trauma resuscitation, and no other physician inside the hospital. The anesthesiologists are posted in the ward, and every postoperative complication is managed by anesthesiologist. There are 14 anesthesiologists on call in the night to do trauma resuscitation, look after the high dependency unit, intensive care unit. So I urge all of those who are attending this session to consider creating systems and protocols in the institutions in which they work to create that visibility for anesthesiologists who are empowered with the best skill, knowledge, and wisdom to treat patients pre, intra, and post. I'm confident this session of College of ISA would give those necessary insights for all those who are attending the session, especially those leaders in anesthesiology, both in corporate sector, in the government sector, working in institutions, take up on them the responsibility to create this pathway and make every young postgraduate to consider, to embark on this journey, to enhance their capacity, to become an excellent physician so that not only the outcome, but outcome of the specialty itself is going to be very, very good. We need to leave a legacy behind. If this generation works hard, the next generation of anesthesiologists will be one of the most happiest one because of the pride that they have on becoming an anesthesiologist. So let us strive hard to create that visibility and to put this field into a very high pedestal because of our dedication to the system. I once again thank Dr. Vibha for giving us this theme, and I thank the entire leadership of Wfsa and ISA for taking this up. On behalf of the board and on behalf of President Dr. Carolina Haylocker-Liu, I thank all our Indian leadership for taking up this webinar and propagating the presidential theme. And I'm confident that the next 2 years, India will see a resurgence of anesthesiologists becoming perioperative physician. Sincere thanks for the opportunity, and I'm sure this webinar will give such impactful messages to all concerned and to the country. Thank you so much, Vibha.
Thank you, sir. Thank you so much for that inspiring message. And like you said, that though the vision is global, I think the diversity that's seen across the globe is almost what we would get to see in our country, because our country itself has various types of health centers and health services that are being provided. I think even Naveen sir mentioned this, that we need to consider all the aspects depending on the type of hospital or type of institution that we all come from. So thank you so much. I'm sure each one, if we take a small step forward, we are all moving towards the same direction. Thank you so much, sir.
Thank you so much.
Right. Thank you. And now we would move on to the panel discussion. And for this, I'm going to start introducing our distinguished faculty. We have with us Dr. Balabhaskar sir, who is the deputy editor at the Update in Anesthesia, which is a WFSA publication. He's also the past president of ISA, past editor-in-chief of IJA, and he's been in the publications committee of World Federation Society of Anesthesiologists. He's been a part of ISA clinical practice guidelines and has numerous publications to his credit. Warm welcome to you, sir. I would also want to invite Dr. Major M.V. Bhimeshwar sir. Sir is the member of the Constitutional Committee of WFSA. He is the past Vice Chancellor of College of ISA, past academic chairman, and past president of ISA. And he's also the academic senate member and member of Board of Studies of NTR University, as well as BLD University. Thank you for joining us here today, sir. Along with them, it is my pleasure to welcome Dr. Anju Garewal ma'am, who is Professor Head of Anesthesiology, AIIMS Katinda, and Editor-in-Chief of Anesthesia Tutorial of the Week, something that's widely read, particularly amongst the younger generation. Ma'am is also the president of Association of Obstetric Anesthesiologists. She's the president-elect of Research Society of Anesthesia and past editor-in-chief of GOACP. So, and with a lot of publications to her credit, thank you, ma'am, for joining us today. We are looking forward to listening to your thoughts and views. Along with her, it's my pleasure to include it's my pleasure to welcome Dr. Geeta Nath ma'am. Ma'am is Joint Editor-in-Chief of the Anesthesia Online Learning Committee, which has recently started a part of the WFSA initiative. She's also a member of the Obstetric Anesthesia Committee of WFSA. She's the lead for Research and Guidelines Committee of Indian Association of Pediatric Anesthesiologists. She's the president of Indian Association for Vital Anesthesia Simulation Training. She's very passionate about simulation. And she's also the EC member with Association of Obstetric Anesthesiologists, having held positions of president at ISA Hyderabad as well as IAPA Telangana State. Thank you, ma'am, for joining us here today. And it's my pleasure to welcome Dr. Rakesh Garg sir, Professor AIIMS Delhi. Sir is Joint Editor-in-Chief with Dr. Geeta Nath ma'am at the Anesthesia Online Learning Community, WFSA. He's the Editor-in-Chief of the only Onco-Anesthesia Journal, JOAPM. He's the past Editor-in-Chief of IJA, past Vice President of All India Difficult Airway Association, and he has a lot of research activities to his credit, including guidelines, formulating courses, programs, huge number of publications, as you can see there, a very distinguished academician. Welcome, sir. Indeed, my pleasure to welcome Dr. Sheila Nayanan Matra ma'am, Professor and Head, Division of Critical Care Medicine at Tata Memorial Hospital, Mumbai. Ma'am is past president of ISCCM, as well as All India Difficult Airway Association. She is the second consecutive time chair of the Critical Care Medicine Committee of WFSA. And I also wanted to say that the clinical lead position for the year before I took up was held by Sheila Naina ma'am. She's also the Dean of Research of College of ISA, and she is ranked amongst very prestigious ranking by the Stanford University of top 2% global researchers. She's been involved in developing airway guidelines and has a new tidal volume challenge test to her credit. Thank you, ma'am, for joining us here today. Next, I welcome Dr. Ekta Rai, who's Professor, Department of Anaesthesiology, CMC Vellore. She is also the Chair, Education Committee of WFSA, a very prestigious position, I would think. She is also WFSA Pediatric Anesthesia Fellowship Course Coordinator. She's Chair, Board of Studies for the Tamil Nadu MGR University, as well as the ASPA Fellowship and the KMC Manipal University. She's the President of ISA Vellore City, Joint Secretary for the Tamil Nadu chapter of IAPA, and she holds editorial positions in respected journals. Thank you, Ekta, for joining us here today. Along with her, indeed my pleasure to welcome charismatic Dr. Vrushali Ponde, who's the founder director of Children's Anesthesia Services, Mumbai. She is the president of Asian Society of Pediatric Anesthesiologists, deputy chair of Pediatric Anesthesia Committee with WFSA. She's also the program head for Pediatric Regional Anesthesia with WFSA. And she's been involved with AORA, right as founder trustee, then chairperson, as a part of board of studies, and has also held the presidential position. And she's the associate editor at RAPM. Thank you, Dr. Vrushali, for joining us here today. It's also my pleasure to welcome Dr. Sukhvinder Bajwa, sir, Dean and Principal, College of Medical Sciences, Ambala. Sir, as we know, is the past Secretary, ISA National, and he also is, he's held the National Governing Council member post of ISA. He's the editor-in-chief of he's the editor-in-chief of journal PEAK, which is Practical Evidence in Anesthesia Knowledge, and he's the executive editor of IJA. He's the associate editor-in-chief of JOACP and is on the editorial board of multiple national and international journals. He has numerous publications and book chapters to his credit. He's also ranked amongst the top 2% scientists in the Stanford list in 2024. Thank you, sir, for joining us here today. Indeed, a pleasure to invite Dr. Murli Tondebavi, who's a senior consultant anesthesiologist at Apollo Hospitals, Bangalore. He has been elected as the Governing Council member of ISA National. He's also taken over as the president of Academy of Regional Anesthesia, India. He's the associate dean of Textbook and Monographs Deanery with College of ISA. He's a member of Workforce Wellbeing Committee at WFSA and also is part of the Communications Committee at ILCOR. He's the president of Indian Society for Study of Pain Karnataka chapter and also the founding National Council member of APSF, Anesthesia Patient Safety Association. He's the member of Board of Studies, AORA, and I really liked the book that he's authored, How to Think Like an Anesthesiologist. Thank you, Dr. Murli, for joining us here today. With him, it's my pleasure to welcome Dr. T. Shivshanmugam, sir, who is a professor, Department of Anaesthesiology, JIPMER, Pondicherry. He is a member of Education Committee of WFSA, Program Director of Fellowships in Ultrasound Guided Regional Anesthesia. He's also a member of Board of Studies for AORA Fellowship and has numerous publications with H-index of 13. He has 10 copyrights and 4 patents to his credit. Thank you, sir, for joining us. And also my pleasure to invite Dr. Swagata Tripathi, professor and in charge of ICU at AIIMS Bhubaneswar. She is a fellow neuroanesthesia at Walton Center, Liverpool. She's the vice president of Society of Neurocritical Care India, member of the Intensive Critical Care Committee, WFSA. She's also member of the National Brain Death Committee, national co-lead for the Indian Registry of Intensive Care, associate editor of IJCCM. What interests me is that she's pursuing PhD with University of Edinburgh. So thank you, Dr. Swagata, for joining us today. And last but not the least, a good friend, Dr. Neha, professor at AIIMS Bhubaneswar. She is a part of the WFSA Safety and Quality Committee, and she has won WFSA Innovation Award in 2015, WCA Scholarship Winner 2021. She is the executive committee member with Aora India and a lot of publications to her credit. Thank you, Dr. Neha, for joining us today. Right. So with all our panelists on board, we are now going to begin the panel discussion. And for this, I now hand it over to Dr. Rajiv Gupta, sir.
Thank you, Dr. Vibhavri, for introducing such a galaxy of panelists amongst us. And out of those, first of all, I would like to invite Dr. Sukhvinderjeet Singh Bajwa to give his comments or his experience, and in line with the theme of WFSA, why should the role of an anesthesiologist should evolve? Why they should not be constrained to operation theater, and why their experience and expertise should be required to go to the another fields also. How the patients can be benefited by the role of an anesthesiologist, how they are so important for the safety and health of the patients. So I'd like to invite Dr. Sukhvinderjeet Singh Bajwa for his expert comments on that.
Thank you, Dr. Rajiv Gupta, sir, our Honorary Secretary of ISA. And first of all, greetings from my side to our President, ISA National, Dr. Naveen Malhotra, the immediate past President, Dr. Bala Venkat, sir. And my first President of my tenure, Dr. Vimeshwar, sir. And all the colleagues, seniors. I think it is a very good initiative on the part of the current governing council to initiate this type of a webinar. And coming to the question, I think the suggestions, opinions which have been asked from my side, I think already half of things have been answered by the Dr. Naveen Malhotra, Dr. Uma Maheshwar Rao, regarding majority of the answers, I think already packed in those punches. How the role has evolved. I think considering our nation only, I will like to say that role has not evolved. It has always the last 3 decades. The revolution has been there. The anesthesiologists have been everywhere. Just like, the Sikh community and the potatoes, they can be found everywhere in the world. Anesthesiologists can be seen in every specialty, you say, in everywhere. And right from the growth as society, as a fraternity, which has hardly barely 200 years, less than 200 years old, has seen a revolutionized and evolutionary growth exponentially over the last 3 decades. If you ask me a further evolution, I think they are doing it every day. No specialty has been that much instrumental in giving birth to the modern sciences. As Dr. Uma Maheshwar sir and Dr. Naveen sir said, you talk about the critical care, you talk about the pain medicine, you talk about the emergency medicine, you talk about the resuscitative sciences, you talk about the perioperative sciences, you talk about the trauma medicine. Tell me single branch where anesthesiologist is not involved in a pivotal role. Even the government of India, 2014, the NMC started the emergency medicine in India. And the only specialty they can trust, they can depend, they can rely upon was anesthesiology. Later on, the different courses came, and then the emergency medicine itself has evolved now as a specialty, but it was anesthesiology. Similar for the critical care sciences, which evolved 3 decades ago. Now you may be having a DRNB critical care, and ISA has been instrumental in bringing back the anesthesiology as a 40% syllabus for the critical cares. This one, whosoever want to join the DRNB from our specialty. So the evolution has already been there. The role has already been there. The only thing is the perspective, the patient care pathway. If you ask me, all these specialties and the modern sciences, they are focusing on the precision medicine, a focused treatment interventions, which has really improved the outcomes of the patients. Anesthesiologists alone cannot do, but with these coordination, the birth of these specialties, the treatment pattern has changed altogether. And if you ask further, the government of India, whether they are starting any project, any guidelines, or any role, the anesthesiologists are the prime people in that. For every guidelines, I think anesthesiologists are always there. And more importantly, I think from the last year, even the Planning Commission of India, when it comes to the policy making into the health issues, the president of ISA National is always involved into that. So that's what achievement of anesthesiologists has taken over for the last few years now. Even if you ask about the administration, you talk about entire country, whether it's a corporate sector, it's a medical college, or a smaller hospitals, you will see anesthesiologists are in a various positions everywhere. They're part of the management, they're a part of the administration, the policy formulations. No specialty is that much holistic in approach in evolving the medical sciences or the surgical science in the country as anesthesiologists are. You may ask about the NORA, you may have non-operating room anesthesia, wherever they go. No specialty has got that much of a daring and that much of a precision, that much of wisdom to give anesthesia or a treatment at that particular place. The COVID was the watershed era in our specialty. The globally we were recognized as a people who are the first one to initiate the treatment of COVID, where even the family members left you alone. The COVID warriors were there. We were given the name of the COVID warriors, and that has, I think, given a special recognition to our society. So the role has evolved over the decades, and it's not a single day story. And I think in the coming future, what our younger generation should be seeing, I want to see the name changing from anesthesiology, from a traditional name to anesthesiology and interventional sciences. That's the name to be given because tomorrow it may be the base for your future cardiological intervention cardiology sciences, critical care nephrosciences, or interventional pulmonology. So these branches, our specialty may be the base for, or NMC may have passed the biochemistry as a, the base subject for endocrinology. Why not our science? Why not our specialty be the base for these type of newer sciences going to the future? That's the role going to be emerging, and that will give a special recognition to our specialty. So I can say this is not even 10 years, maybe lesser than that. It will be entirely a different revolutionary path for our roles in different fields away from operative arena. Thank you very much.
Thank you, sir. Thank you. Thank you for sharing your thoughts. I completely agree that a lot of us are already moving out of the operating rooms. However, two things that I wanted to say again. I think the scenario across India is slightly different. And while we really hope and aim to be doing these things, we actually need to see how each one of us can be taken along while we walk along this pathway. So what I found very interesting in what you said, Sukhminder sir, is anesthesiology and interventional sciences. I mean, perioperative physician is something very commonly heard, but yeah, very interesting idea, interventional sciences. there is already a lot of competition in the interventional area with surgeons, the radiologists, and different branches wanting to be in there. Interesting concept. Thank you. Thank you, sir. I think we've heard a lot about the way we need to move out of the operating room, expanding into the other clinical areas. But what does it really specifically mean when it comes to specific areas? And I'm sure everyone will agree that obstetric anesthesia is something that most anesthesiologists get to do a lot. It is almost like bread and butter for most of them. So for this, I'm going to request Dr. Geeta Nath, ma'am, to tell us what does this theme really mean for someone who practices obstetric anesthesia? Is it important that we move beyond the typical operating room interaction wherein we meet the patient just before the spinal is administered and then leave once the patient is safe and the skin is closed? Is it adequate? Do we need to do more? Why do we need to do more? And how can someone, not just in a good institution working like many of us who've joined in here today, but also those who practice, probably they are the sole anesthetists covering a couple of hospitals. What things can they do if they want to align to this pathway and theme? Over to you, ma'am.
Thank you, Vibha. First of all, thank you for involving me in this webinar. It's a great privilege. Let me get down to brass tacks because we don't have that much time, so I'll just get down to the matter. So let us first see what are the main areas where patients, mothers need help, need support in their journey, of having babies. They need during pregnancy, during childbirth, in the peripartum area, and also in the non-pregnant period, before and after, they've had the baby. We need to look at outcomes because we need some way of assessing what is happening now and what we are doing, what we should do. So the easiest way to assess maternal outcomes is mortality. It's currently about 90 per 100,000 live births. So, which is good, but are we looking at a very narrow area? Because other outcomes are also important. For each maternal death, there are 9 near misses which happen, okay, which put the patient at risk, right? See, each of these areas, if we can reduce the risk, we can improve the outcomes. So near misses is one thing. Then morbidity, when we talk about morbidity, nobody looks at the morbidity of the woman who has had a baby. She may have acute morbidity, which maybe people run around and treat, but chronic morbidity again is not really looked at because you can have long-term effects also on the mother's health. It can have physical effects, psychological effects, economic effects, because if this morbidity interferes with her, like we are talking about patients in all strata of life. You talk about the kondama who comes and has a baby. She comes out and she can't do her work in the fields. I mean, that's a big disaster for her. So we have to think of the whole spectrum of patients. So the question is, how can we as anesthesiologists help in improving the maternal outcomes, right? Around childbirth, our role is quite clear, in the peripartum period. As you said, most of the members of ISA even, they think giving anesthesia for cesarean section is obstetric anesthesia. Obviously, we know that's not true, but usually they come, as you said, before the spinal, they give the spinal and they go away after the baby is out, maybe before closure. I mean, all sorts of standards are there, which are not being maintained in the various setups that we have. So if this is a patient coming for a section. But if she's not coming for a section, she's just having, she's in labor, we don't see her at all. In most setups, they don't come to our notice at all, because they have, no, the obstetricians are looking after them, and they don't refer the patient to us anesthetists unless she is going to have a section. Obviously, this is not true anywhere there, which has a labor analgesia setup, or that kind of thing. Or but in general, in private and government setups, this is the situation, that mothers don't get the option of pain relief. Majority of mothers don't get the option for pain relief. So all these are the areas where we need to improve. We need a woman-centric approach. It has to be collaborative. We have to have different specialties, mainly obstetrics, because that would be one of the barriers. So during pregnancy, the patient is under obstetrician, but they should be referred to us if there is any complicating comorbidity, so that we can assess, optimize, and plan for the delivery. And in labor, as I said, the anesthetist should plan with the obstetricians in that setup to have some kind of thing for non-neuraxial pain relief, but something, so that even if it's not perfect, something is there for the woman. I mean, I've heard people say that paracetamol, I mean, where it's absolutely no use giving paracetamol for labor pain. Then, of course, in the postpartum, if the patient has any critical event, the anesthetist is absolutely involved in looking after the patient. But here, a simple thing that can be implemented is to have early warning scores, so that any patient who is likely to deteriorate can be picked up, and then the care is escalated, so that again the acute morbidity, chronic morbidity, and maybe mortality can all be reduced. So obviously there's going to be lots of barriers, opposition from the obstetricians, from the administration. Why are you interfering with all this? I've had that. But from the nursing as well. But as a national society, I think we at the ISA should help to set up these kind of protocols, so that every mother everywhere gets optimal care, around her childbirth. So that's my view. Sorry. Thank you.
Thank you, Dr. Geeta, for elaborating how a mother should feel and how a mother should be protected from pain and all the ailments she get during pregnancy, post-pregnancy. And there are so many government schemes also favoring them. And yes, but there is scarcity of anesthesiologists who can very well take care of these mothers. And you rightly said maternal mortality, not only mortality, but morbidity is also very important that we need to take care. But mostly these things are taken care of by the obstetricians, not by us. Because, because of scarcity of anesthesiologists, even you don't want to be involved in the normal care of the pregnant patient, unless you're called for a cesarean or some other kind of things, like, so your involvement is very, very much less than what is expected and what is required. So in this scenario, we should have certain schemes, or we should sit with the government to formulate the policies so that maternal care can be given in a good shape. Yeah. So this is the right of each and every woman to get the best care. But because of, at different places, uh, you know,
Barriers.
barriers are there, and there are so many things which are lacking. So we need to sit with them, and we need to formulate a policy so that each and every pregnant woman or mother should get optimal care, which is
We
required
need
by
to collaborate with the
definitely.
obstetricians and, from the higher ups as well,
Right.
because a single anesthetist cannot do anything.
Absolutely, absolutely. So with this, I would like to invite Dr. Rushali Pandey, in continuation with this, that once, mother care is taken care of, so how to go about the pediatric patients, how we should take them in a way that they get the best care. What should be the pathway and how we should move forward to take care of the pediatric patients? So, Dr. Vishali.
Well, happy evening to everybody, and a very warm namaste to everybody who is here. And thank you, Dr. Rajiv, to have been thoughtful to put this in a pathway that is following the mother, the baby, now the pediatric anesthesia. That itself is very thoughtful. Well, I just still feel, looking at the entire bird's eye view of anesthesia as such, at least in India, I still feel majority of the Indian population does feel that anesthesiologist is somebody who is there probably to induce, rather start the anesthesia, and that's all the role is. So it's very interesting that the WFSA president has taken up this, and it's very interesting that we are working on towards that as well in a very constructive way as I see it. Where does the pathway start? Pathway has to have a beginning and an end. So where does it start? It starts probably not just in the hospital. It starts in the society where the hospital stands. So that's the premise of the hospital, is our entire society. In other words, entire country, if you're only speaking of India. So this means that pediatric anesthesia per se, because this is what my domain to speak on is, then there has to be an education about what pediatric anesthesiologist is all about, what pediatric anesthesia can offer, and how are they different, and why a different person is required. Why is this a specialty in the first case? So I think the pathway begins from there. I think me and my colleagues, my team, we work as children's anesthesia services since decades now. And we thought about it quite a while ago. I feel, I don't recall who, but somebody was saying, I think Dr. Bajwa was saying, we already do it. Now it's a time for us to consolidate and go ahead with it in a very systematic manner. So we had our FAQs and we had what is pediatric anesthesia. You can visit the website and it's open for everybody. We make it a point to tell our parents to visit that website. There are FAQs, there are fasting guidelines, there is what is pre-medication, what is induction, what has to be expected. So I guess it starts from there. So awareness in the community is something that has to be started. There can be many interesting ways of doing it. There could be short videos, there could be short gatherings, there could be school visits, there could be so many things that we could do. So community awareness is the first step of the pathway. Now coming to the gate of the hospital. So the child is going to enter the gate of the hospital. He's going to see, the parents are going to see a lot of OPDs. I guess there should be a pediatric anesthesia OPD as well, which is going to take care of PACs, which is going to take care perhaps of chronic pain as well, which is going to take care of lingering post-operative pain too. So it can be all in one at that time, and it can be manned. So again, in one or two hospitals where we work, say for example, Surya Children Hospital, we do have an OPD which is dedicated, or if at all a child walks in, not during the OPD hours, we are contacted and children come to the pre-op wards. I am just giving you an example so that I can share what thoughts are flowing through my head currently. So I guess that is the second step. And yes, Dr. Bajwa and everybody has been talking about the fact that we can optimize. We always have been doing it. We optimize. We act as perioperative physician. Dr. Bala said that. Dr. Naveen was talking about the same thing all over. I think we all mean the same. I think then we come into picture. I don't think gone are the eras where pediatricians gave us fitness for pediatric anesthesia. I think pediatric anesthesiologists should be giving fitnesses. We are absolutely open-minded to optimize our patients through their knowledge, because we know little bit of everything, you see. we are expected to know everything. That's the beauty of anesthesiology, and even more pediatric anesthesiology. We are supposed to know neuro. We know. I mean, yes, we try to. Uh, However, we claim that there is a specialist, and the kid should go to the specialist, get, say, seizing child, or say an asthmatic baby, or say a cerebral palsy. Let them be optimized for the condition that they are for. But final fitness is the pediatric anesthesiologist word, because we are the ones who are going to take care of the baby in the intraoperative period. And we very vociferously have changed it in our practice. So we find it very interesting when somebody gives a fitness for anesthesia. Anyway, we have our own ways of dealing with it, and we've dealt it, I guess, by now. Now, what happens is the child is walking in, goes to the surgeon's OPD, then comes to the anesthesia OPD, meets the anesthesiologist. The anesthesiologist now gets a chance of befriending the family as well as the kid. Depends upon how conversationalist is the person, the anesthesiologist, and how much he or she likes children. And we all do, because we are in that specialty. And then how friendly are we and our atmosphere in the OT, or now in the preoperative room, or the the pre-medication room for that matter. How friendly, how warm is the atmosphere for the child? How warm are we? How are we present and conscious about what the family is going through? How have we kept things that might be scary, say some other patient getting driven inside the room, curtained? So many small things. I mean, pathways will only show us poles, you see, but so many small things go in pediatric anesthesia, because children are clean slates. They're not going to differentiate reality, and they're not going to differentiate that's not my reality and that is somebody else's reality. They are just going to get fearful. So that is how they are, aren't they? Uh, so this is what I call a child-friendly hospital. It works as an ethos towards pediatric anesthesia. This is what I feel. A child life support it is. It improves the entire experience. We need to be evangelizing when we take pediatric anesthesia. So this is what it is. Now, if the child is posted for surgery, our job is to give fitness. Our job is to see to it that the child doesn't get fasted too much. Our job is to see to it that the child's condition is optimized. Our job is to see to it that the child comes in playfully with us as much as it can. Or we do everything that we could for that. All that it takes, we wear funny clothes. We probably will give midazolam along with sugar. We will do many things, trust us. Maybe they still don't, but we accept it at that time. We go to visual aids. So there are, okay, I leave it as pre-medication. I leave it as preparing. Sometimes I feel even parents need some pre-medication. Okay, having said that, this is how the outside OT scenario would be. Now, inside OT scenario is again us, cold OTs, different faces with masks. A lot of thought process goes on. A calm voice helps. Music helps. Nursery rhymes or age appropriate music helps. Sense helps. A long induction, but we are trained to do this, so we do it. So that's another pole in the pathway, another bus stop in the pathway. All right. Now let's come to post-operative period. Intraoperatively, pain management is 100% because we are there. Post-operatively, we want it to linger for sure in the most beneficial manner to the child and the surgical team as well. We don't want them to give dead extremities. We don't want them to worry about what we do. We want them to be aided by us. A pain-free patient who can move around well is what we would like. No nausea, vomiting, no respiratory depression. This is what we would like. This percolates very beautifully in one of our audits that we did, 400 cerebral palsy patients, and how we succeeded and where we failed. Or 1,000 preterm neonates, how we did without no airway instrumentation. Again, few bus stops, few stops to go, and look behind, so that we make it safer and safer and safer. So this goes beyond post-operative period. So all of us are talking about acute pain services. Yes, it's a tad bit different in children because nobody's going to get up and give fentanyl on the floors. Needs a lot of thought. Multimodality, ERAs, they all are there for us to embrace, as it were. Postoperative rounds, something that teaches us so much. Scoliosis with the fentanyl patch and maybe something going on, and a little bit of adjustment, and so much we can do. A little bit of adjustments before the physiotherapist come in and before the pain shot is given does so much. So that's I'm just touching the tip of the iceberg. Coming to critical care and resuscitation, we could be of help here. We could actually be leaders in the OT to teach them what pediatric resuscitation is all about. Pediatric technicians can be taught in pediatric OTs. Nurses can be taught in pediatric OTs. It starts from how not to unnecessarily touch a kid before he goes to sleep, from how to put an LMA or how to draw drugs, how to communicate. Focus, of course. Ultrasound has come up. We are therapeutics now. We can be therapeutic with ultrasound around us. Or in cath labs, we are therapeutics. With regional anesthesia in our hands, we can curb an arrhythmia, which is so deterrent that the antiarrhythmic load in the IV of the child is so much. The serum levels are going shooting high. And one thoracic epidural, we're therapeutic here. And then we're diagnostic too. We can tell the cardiologist, go ahead, a temporary sympathectomy by a thoracic epidural is showing you good result. Go ahead, post the child for a thoracic sympathectomy, which is a permanent, non-reversible procedure. Oh, we can do so much along the way that we work in. We can be hospital leaders. We can speak to our hospitals. We can tell them what we need. We can show them our results. That's our results is only thing that the administrator is going to listen to. Sometimes my dream is the way people choose their surgeons, by names. They should know the names of anesthesiologists, like Dr. Vibha. She's an anesthesiologist or somebody else. All of us here, they should know our names. How will they know our names if we don't talk to them and introduce ourselves and say what we are doing? So, or don't give our phone numbers to them. If we don't give our phone numbers, it's fine, but let them have our desk phone number, or let them have a phone number through which they can go to if there is an anesthesia or a pain issue in the postoperative period. If we don't own it, how are we going to pave a pathway? So we have to think totally different to understand our roles, because it's a long way to go. It's a long way to go, but I guess we are at it. I think, and all this has to be vociferously made visible to people around. If a surgeon works for 14 hours, don't boast, but say there was a quiet regional block that makes your patient get up in 2 minutes after you finished a plaster or after you have finished your closure. I think we need to learn to become vociferous, and that's how a younger generation is going to take pride and take privilege and feel that they are in a specialty which touches life before even it understands what life is. I think this is
wonderful.
This is what we are. The closing message should be: pediatric anesthesia is here to stay and bloom. There is no end to it, because God is going to give us babies.
Thank you, Vrishali, for explaining so much. I actually like the small practical tips, and I'm sure our audience has also benefited with the small things that you mentioned that can help it become a child-centric place, and also helps in improving the experience of the child as well as the parents. I also see Anju ma'am has replied to some of the comments. Thank you, Anju ma'am, for doing it, because we may or may not be able to take all the questions. So thank you so much. I also see a comment that says that it is difficult to work as a team, even in a group. I am sorry to say, but I think we need to be together when we are evolving in our role, when we are reaching out beyond the the typical core areas. It is very important that we work together as a team. So with this, we move on. So far we've discussed about obstetric, pediatric, and to take the role of anesthesiologists beyond these areas. I think few more important areas like the critical care and the emergency area is where anesthesiologists can make their meaningful mark. And for this, I'm going to invite Dr. Sheila Nayanar Maitra. Ma'am, what I wanted to ask you is that how does anesthesiologist involvement in these areas affect the quality of care? I'm also going to ask you one more question so that you could probably answer it more compressively. What are the opportunities as anesthesiologists take up these roles, and what could be the barriers because of which they may not be able to? Thank you so much.
Yeah, thank you. Good evening. First of all, this discussion is so interesting. I'd rather just listen than speak. But of course, I've been assigned a role. So at the outset, I'd like to thank the President, Dr. Naveen Malhotra, and Dr. Bala, and of course, Dr. Rajiv and Dr. Vibha for organizing, and the entire leadership of ISA and CISA for putting this together. I wear two hats with the WFSA. I'm the third time chair of the critical care section, and I'm also the deputy chair of the Vancouver meeting in 2028, and I'm dean of the CISA. And I think this is such a unique webinar of this ISA CISA, taking the WFSA theme forward. So I think this is truly, truly unique. And I don't think any society across the globe has done this, So I really congratulations, and very, very well planned and very well executed. Now, when I look at, this theme, and a lot has been said about the theme, and what I find really unique at what the President Carolina Haylock has done, and Dr. Naveen already said that, it's not anesthesiologist, but it's, anesthesiology, and, that how the importance of that. And Dr. Bala talked about the along the entire continuum. But I think the word that is unique in this phrase is the care pathway. We often say anesthesiologist, perioperative physician, we always link it to surgery. But here it is, the entire care pathway. So it could be anywhere. So like Dr. Bajwa said, maybe interventional, maybe anything. Wherever a patient needs care, we are there. So I think the way it's worded is really, really unique, and it doesn't put us in a slot that we just have to be in the operating room and around. And coming to critical care, I think, anesthesiologists are very uniquely positioned to do critical care. We, our strengths are our physiology of cardiorespiratory physiology. We are very used to the organ support. We are right there for resuscitation. And even, the organ support, even intraoperatively, what we are providing during major coelomic surgeries. And also there is an ingrained culture of safety that is very important for of this care pathway stuff, So I think we're uniquely positioned to take care of patients in critical care. Nevertheless, there are several, other specialists who come in. And when I look at myself, and as Roshali rightly said, we never project ourselves. I remember my daughter when she was young telling her friend that, my mother is an anesthesiologist. She puts patients to sleep. So, that didn't look as, glorious as, a surgeon doing a heart
Saying that now
surgery
she's
or
a
something
critical
like
care
that.
specialist.
So, I think the mistake is ours, with us, because this is the way people perceive us. This is the way the public looks at us. Okay, the surgeon does the great work, and the anesthesiologist gives one injection and puts the patient to sleep. And the reason, of course, is because we are really happy working behind the scenes and just completing the case and going away. How many of us really talk to the patient preoperatively, tell them, look, we are anesthesiologists, this is what we do, I'm going to keep you safe through surgery, or postoperatively, like, yes, the surgery went well, but there was blood loss, this was what was happening. And, they never look at us as somebody who's really there through the care pathway. And I think, that's something that, we really have to look into if we want to be outside the operating room and, be big in the other area. I think the COVID was a real game changer for anesthesiology, and it put us it really exposed to not only to the public, but also to the medical community about the importance of the role of anesthesiologists, because it was not surgical patients who were coming to us, it was medical patients with respiratory failure who were coming to us, and it was not the physicians who could manage them, but it was the anesthesiologists who were at the forefront. But here I think somewhere we were just happy with a picture coming on Time magazine and getting credit everywhere. I think it was a bit of a lost opportunity. I think we could have taken this even further, grabbed the opportunity and got a lot more mileage for ourselves, especially the role of anesthesiologists in the entire care pathway could have been, through governments, through organizations and other things. I think we could have done much more. And I feel that was a lost opportunity. So a lot of strengths for anesthesiologists to do critical care. But as you know, when you come into the intensive care domain, you're not competing with anesthesiologists. We have physicians, we have pulmonologists, we have surgeon intensivists, we have emergency medicine. So there are different specialties. And unfortunately, critical care started with anesthesia as post-operative care. And it is something that we lost to the other specialties because, we said, okay, we didn't bother about it. And we said, we are happy, just being in the operating room and, doing our stuff. But now at the moment, it's a huge dominance of the non-anesthesiologists. And, if you look, especially in the private sectors, when I listen to my colleagues and they say, oh, just come intubate the patient, put lines and that's it. They look at you as someone who's just hired to do the procedure. And that's not the way an anesthesiologist should be as an intensivist. And if we want to change this, we really need to think, we say anesthesia is intensive care. Are we really intensive care? Because recently we did this survey through the Wfsa of about 1,200 recently trained anesthesiologists from 82 countries. And we asked these newly trained anesthesiologists who just finished their training within 3 years, we asked them this question. We put all the domains that are required for critical care, all the competencies, and we asked them, how comfortable do you feel? How confident do you feel with these procedures? And you know what? It was only 54% of the competencies anesthesiologists felt. And this was, people usually say higher than what actually is, but it was that low. So obviously, our curriculum does not include how do you prescribe antibiotics, how do you do dialysis, how do you give ECMO. There are many, many things in critical care. So if we really have to take ourselves and say we are critical care, we are perioperative, then there are many, many things that we have to train in. And the idea of doing this survey was to identify what are the lacunae and what are the gaps, and to revisit our curriculum and see how we could strengthen this further to make anesthesiologists better equipped to do critical care. So I think, like physicians need to learn many other things and other specialists, we need to really step back and think that if we want to become really good at critical care, what are the gaps and where should we be focusing our training on if we want to be in that competition, and physicians saying, oh, just do procedures and, look at us as just someone who does resuscitation and doesn't know how to make a diagnosis, And that's where I see a lot of anesthesiologists feel a little inferior or feel, like a second-class person in intensive care, which shouldn't be, because some of the best intensivists are anesthesiologists. The challenges are that hospitals don't look at us as getting patients. A lot of times that is something physicians do. So that is something that can be a bit of a weakness for us because we don't directly admit patients. But there are many other strengths that we have that can overcome these things. And other things that I see as challenges in this area are that there's anesthesiologist is one specialty where there's always a shortage. We are always short-staffed. We're short-staffed even for the operating room. In any hospital across the globe I'd go, they say there's a shortage of anesthesiologists, for some reason, though there's so many of us. So this also becomes a challenge to, push people into intensive care, even in the hospitals, and they're happy with other people managing. Many hospitals say, oh, we're happy with the emergency department looking after the critical care, and we're losing this to the people. So I think a concerted effort to up our skills and to accept that we're great at resuscitation, we're great at, patient safety, we're great at doing this, but it has to go beyond to making a diagnosis, to making treatment, to plan, and we need to train further. And we also need to work more collaboratively. I like that word collaborative that Geeta ma'am said, with other specialties, and not look at ourselves as, either superior or as rivals of these people. Because I've seen that whenever you work in a cohesive way with the other specialties, that's where, you can really be one up. And one of the things I've noticed, and especially post-COVID, is the administration in hospitals is very happy to call the anesthesiologist, because they know that, if you want to liaise with negotiate with the surgeons, the anesthesiologists are good. If it's a physician in critical care and this thing, anesthesiologists, we cut across all these specialties, and we're very good at making this kind of bridge. And we are generally multitaskers, so we're pretty good at, and also good at communication, especially, dealing with difficult surgeons every day. So I think these are our strengths, and there are threats. but looking at critical care as a dynamic specialty, which is really, really growing so fast. I have trainees who come for anesthesia with us, and they'll end up doing critical care because it's just such an upcoming new specialty. There's so much so attractive, and also the money incentive that we need to really make sure that we are the ones leading it, like we had started it, the specialty. So thank you for this. These are just my insights, but I'm sure others have other thoughts on the challenges and the opportunities that we have. Thank you. Thank you for this opportunity.
Thank you, Dr. Sheila, for nicely elaborating how an anesthetist works in critical care, what are the challenges, and how to cope about. So, rightly said, conversing with your fellow colleagues and keeping pace with them, that is the best thing you can do in the critical care so that you are one up. And particularly in critical care, you are not behind the scene. You are in the front. You are the front runner because all those specialty who comes to the ICU, they come for a round, means morning round, evening round. They meet with the patient and the attendants for a very few minutes, but you are there all around. So your interaction with the attendants is very much. So that way, critical care specialists, they get good credit about what they are doing for the patients. You can explain them well because you are there for the most of the time. So that is how critical care works, and I'm very happy that you're one of the finest critical care specialists in our specialty. So thank you so much, Dr. Sheila. Now, when we talk of surgery, when we talk of pain, when we talk of acute pain, equally important is the chronic pain. So when I was, doing my fellowship in pain, so I used to ask my mentor, why you call it as subspecialty? Why it is not super specialty? So he used to say, because, we are not recognized that much. Now we are in a position that we are holding chronic pain as an anesthesiologist, but I am seeing that over a period of a decade, it has turned to a super specialty. So there's something, very good. And I would like to call upon Dr. Naveen Malhotra, who is a chronic pain physician. He has worked for so long in the government setup, and now he is working in his private setup. So he has his own experience about the chronic pain. So I would like to invite Dr. Naveen Malhotra, sir.
Thank you, Dr. Rajiv. And yes, I'm very happy that over the last decade or so, it has become a super specialty. And more so because now we have got recognized super specialty courses in pain medicine. We've got DM pain medicine running in All India institutes, and we have got fellowship of National Board in Pain Medicine. And it's personally gratifying for me because when I was chairperson of the Specialties Board of Anaesthesiology, National Board of Examination, during that time only we had sanctioned this course, and now it is running across the country. And yes, as pain physician, I am a full-time pain physician. Yes, I agree. And 24/7, I am doing chronic pain, and not doing alone, but with my team also, whether it was in the institute or with Dr. Neha and Dr. Amit at my pain management center at Rohtak, Haryana. And we are in direct contact with the patient. The society recognizes you because like critical care, you are in touch with the patients and their attendants. Now, but to be honest, we have started DM pain medicine, we have started FNB pain medicine. One more important information I'd like to share is that soon we are going, NMC should sanction DM pain medicine in medical colleges also. The file is in the final stages. Do we require super specialty courses? Yes, because at any given point of time, as per the published literature, 28% of the population is suffering from chronic pain in India. And imagine we are 145 crore plus. So roughly 30 crore patients are suffering from chronic pain at any given point of time. And right now, we have 5,000 chronic pain physicians in India, and out of which 1,000 are only practicing chronic pain exclusively. Rest 4,000 are doing anesthesia and chronic pain. So there is a big gap between the requirement and full-time chronic pain physicians. So I'll use this platform to urge all of you to motivate youngsters and elders across to take chronic pain exclusively in career. And the advantages of being a pain physician are, first, you are in direct contact with the patients. You do interventions which we are very fond of, whether they are USG guided or fluoroscope guided. You are having I firmly believe who better than anesthesiologist. Our duty, our profession of relieving pain, and we are naturally extending into chronic pain. This we have been doing, relieving pain throughout our career. And so who better than us? Then you have got a very good work-life balance. There are very few emergencies in chronic pain, I can tell you. There are some. And you're totally independent of the surgeons. You can plan your patients accordingly. It is financially also very, very rewarding. You can add any number of zeros after one. Take my word, after putting 1 year of dedicated work. And you can have a quality family time. It's not like that you're cutting cake of your father's 50th anniversary and emergency cesarean call comes and you have to go in between. And above all, you get tons and tons of blessings of patients whom you relieve from chronic pain. And those blessings help in overcoming the hurdles of your own life also. So it's not only financially rewarding, but socially also and spiritually also. And you can do n number of teaching, training activities and research. You can run fellowship courses, you can do research also. So it's a holistic thing to be a chronic pain physician, and India needs lakhs and lakhs of pain physicians. So as the ISA National President, who himself is a chronic pain physician, our emphasis is on increasing the avenues of teaching and training under the banner of ISA and College of ISA. And I'm very happy to share with you soon, under the banner of College of ISA, we will start centers of excellence across the country. It will be in the field of chronic pain also, but in other specialties and super specialties also, where the ISCNs will get an opportunity to sharpen their skills, do fellowship courses, certificate courses, refresher courses, orientation courses. And it is an open invitation to all of you to please come and partner with College of ISA and showcase your work, which is not restricted to your state, but to entire country. If somebody is good in supraglottic airway devices, they will need only 2 days to conduct a full showcase of supraglottic airway devices and do a refresher course. Somebody is very good in cardiac anesthesia, they will require a 1-year fellowship course for that. So you can conduct a weekend course to a 1-year course under banner of College of ISA. And India needs lakhs and lakhs of pain physicians. ISA is there to support for these fellowship courses. They will be structured courses with an entrance exam, but which can be interview based, but definitely a structured exit exam. More details will be there shortly. Thank you very much.
Sure. Thank you. Thank you, sir. Thank you for highlighting that the chronic pain burden in India is increasing. And thank you for highlighting that pain medicine is a lucrative and a very thankful branch, and telling us the opportunities that ISA hopes to provide in this area. Thank you so much. So as we move on, so we've spoken about specialty anesthesia, we've spoken about critical care, chronic pain. But while we take up all these responsibilities, it's very important that we consider safety, quality, and patient centricness along the patient pathway. And for this, I'm going to invite Dr. Neha. Dr. Neha, I want you to share what, according to you, are the key safety, quality, and patient experience initiatives that anesthesiologists should incorporate, and what are the ways that they can scale up if they're already doing some of these? Over to you, Dr. Neha.
Thank you, Vibha ma'am. First of all, I would like to thank Naveen sir, Rajiv sir, all the seniors, and to you for having me here with you today. And it's really nice to listen to this discussion and seeing India developing on the global picture as such, with the mindset developing as a perioperative physician and the care pathway. And as already discussed about obstetric and pediatric, it starts from community. I'll stick myself to the perioperative scenario. As such, anesthesia, it's been discussed that it's no longer it's limited to the operative room. We are increasing our horizon from operating room to NORA practice, critical care, obstetric, acute pain, chronic pain, and so on. So for safety protocols and quality indices, if we see, we don't have there is a division in the global picture, if you see, and it's not about India versus world, it's about they have divided it at high income HICs versus LMICs, low middle income countries and high income countries. And coming to the numbers, if you see, numbers differs a lot. For example, if I take just a compliance to the registered protocol, in the infection control compliance, if you see the LMICs versus HMICs, it's only 9% versus 70%. So if we take our picture, we do have mindset, we do have intention to go for safety and for quality. But what lacking here is to stick to the protocols and to stick to the guidelines. And as per according to our local setup, we should always acclimatize to the situation. As sir has already emphasized, we have got three strata practicing: medical colleges, corporate sector, and freelancer. So definitely the resources, the environment, and everything is different from different strata of people working. For example, medical college, you can find some 4 ultrasound machine in department. That is not very common scenario in corporate sector, and freelancers, maybe they are not having ultrasound. We per se, regional anesthesia, ultrasound combining with PNS is increasing the safety. But if you don't have that, then also there are small measures which you can do at your own setup to increase the safety. So it's not only the limited resources and infrastructure, it's a mindset. And whatever possible ways, if I take an example of simple way of hand hygiene, we can contribute too much in decreasing the infection load by just practicing hand hygiene, the protocol in our setup. So it's just a small gesture and small practices which we need to think of to improve the perioperative outcome and to improve the safety and quality. And we need to work little bit more on our compliance, and of course training and education. As sir has already emphasized, the change start from me, but I need to train my students and juniors to follow those things, and I need to play as a role model for the safety and for the quality and increasing the visibility amongst the patient, and teaching them also that okay, this is anesthesia, these are my protocols, and these that's how I'm going to take care of you, be it the transition from pre-operative to the operating room, or from operating room to the post-anesthesia care unit, and afterwards to ward also. And one very nice concept I like with the previous discussion is the ward round. It's really lacking in our specialty, and that's the main factor that we are not visible in spite of giving so much of dedication and like care to the patient. we are not, we are still behind the curtains because of lack of this communication, pre-operative communication or post-operative. So we can work on those things, and we can improve our safety with so many protocols and adhering to the guidelines as such. Thank you so much.
Thank you, madam, for the nice and comprehensive about the quality and safety of the patients. But we also need to see that we have to have parameters, certain parameters also, which we have to adhere to. See how is the outcome of the surgery. So is there any allergic reaction, hypotension, and many other complications that too happen, like failure of the workstation. There are so many quality standards which we have to see in operation theater, and we should have the record of that so that we can monitor them very easily. We can find out what we are doing and what is expected of us, so that there is no harm to the patient. So all these, like, WHO safety checklist, then handling the equipments, because you are the whole and soul in charge of operation theater. So whatever is happening, maybe in anesthesia or the surgery, so responsibility is yours to prevent the SSI, when to give antibiotics, how to go about it, what is the time of induction. So all these things need to be taken care of. So thank you so much for all this thing. Now, I would like to invite Dr. Ekta Rai.
Good evening, sir.
Yeah, she'll be talking about the education and training in anesthesia, what all is required, where are the gaps, and particularly what all is required in the curriculum of anesthesia. Though we read each and everything, we are guided, we are told about the techniques, we are told about and trained about the surgical procedures and interventions also. But along with that, we should also know about how to talk with the patient. What are the ethics we should be taking care of? What are the medical legal aspects? How we should go about when something happens in operation theater? So all these things are very important, and these should be included in our curriculum also. How to talk to the patient, how compassionate we should have been in the operation theater. So over to you, Dr. Ekta Rai.
Thank you, Dr. Rajiv. Thank you, Naveen sir. Thank you, Bala sir. Thank you, Dr. Vibha, for leading us into this interesting topic of presidential theme, anesthesiology along the patient pathway. I mean, I'm really, really enjoying listening to all the stalwarts sitting here. I don't know how much I can contribute, but I'll try my best to say what I feel about education in the current scenario and what can be done. I think the question asked is, what gaps can we fill? Two goals I live by. One is learning never ends. And the second is whatever we talk, the patient safety is the aim for all of us in different ways, be it improving anesthesia, be it improving education for your juniors. So if I ask anybody from any specialty and ask a simple question, why did you take that specialty? I think 50% of the people will say, my teacher was inspiring and I took it because the teacher was so good. So though education doesn't seem like the thing in the safety, but actually if you see, it is the educators who motivate people to take specialty. It is the educator who educate their juniors and they become safe anesthesiologists. So education plays a very vital role. Now, when we talk about our current scenario in India, so education, when we talk about, automatically our brain goes towards the education of students. Whereas the education also is for faculty, whereas education also is for patients. So I'll start with student because that's where first we go. If you talk about the current scenario of education for anesthesiologists, Structurally, I think we are near ideal. You see how it starts, 4.5 years of MBBS, then whatever you learn basic for a medicine guy, you have 1 year of hands-on practice, which is your internship. Then you come and take your specialty like anesthesia, and then you learn the basic anesthesia. And then if you are in institution, you are supposed to do 1 year of SR-ship, which is like practicing what you learn in 3 years. But you are allowed at this point to go and do private practice on your own. Then now this is only basic anesthesia. If you have to really expand your roles as a perioperative physician, as somebody who can do interventions for the patient, as Bajwa very correctly said, that you have opportunity there. Then you cannot just say that I am MD and I'm going ahead and I'm taking care of everything, because we have to remember that patient safety is the priority. We cannot keep learning on patient and harming them while we are, on the job learning our things. So education plays a very, very important role here. So now what happens is you have to undergo some further training. It could be a fellowship, which is primarily aiming to improve your skills. It could be your FNB. It could be 2 years program. It could be 3 years DM. So you further go and you specialize in the subspecialty or super specialty, as Naveen sir said. And after that, you kind of feel that, okay, now I'm okay to go. But remember, learning never ends. So you continue to learn as you are growing. Now, structurally looks very good. But when we talk about functionality of it, I think what we lack in India is standardization. Not every center is the same. So I think at some point, time has come that we focus on functionality, standardization. I think NMC is already working on it. There's exit exam, all those discussions are happening. So I think we are realizing the need of standardization, and we are working on it. Now, when I talk about education of a student, how we educate them, there are many ways. Like you can just go to the class and take a didactic lecture, which half of the people will sleep, half of the students will sleep in the class, and it's so embarrassing for the teacher. You're seeing yawning students. It's really embarrassing. But that's the point. You have to understand the styling of education has to change. You need to make it more small group teaching. You need to bring digitalization into action. You need to make simulation. You can have case discussions, and which we are already working. And on top of this, in your institution, you may not get all experts. So it is important to go to the conferences, for the small workshops, and learn from the experts who are coming from different part of country. Now, when I talk about, so I think this is pretty much, we are doing it and it's happening. What can be improved, I feel, is the faculty education. I feel there is no talk about faculty education. Once you finish 3 years of MD, you become faculty, and after that, it is only a promotion which decides you are growing forward or not. And the other thing which NMC has got is some CME points, but that's very bare minimum. So I think time has come to think about there should be some structured education for faculty. We need to also see whether we are capable to teach. That also is a point which probably in future we can think about. So I mean, that's about faculty education. I think this is the gap we need to fill, and I'm sure Naveen sir is there, Bajwa sir is there, Bala sir is there. I think ISA seniors are there. We can focus on it, and in our conferences, especially ISA, I think we should talk about these things. We should talk about faculty education. And the education doesn't end with only anesthesiology and the faculty or the student. I think it's important also to talk about patients' education, which I think most of you have already said, that we need to go to community and, make patients aware of what is general anesthesia, what is to expect after general anesthesia. So all these awareness programs also will play. Like I know ISA is doing a lot into resuscitation. So these kind of things are very, very important, patients' awareness. So, I mean, I would say, Yeah, I would say education, these three aspects. And as Dr. Rajiv already mentioned, we are not covering all the perspectives of education. Anesthesia is not only about how to give general anesthesia, how to put spinal anesthesia. And in this current world or in this current scenario where the threat to doctor also is equally high, it's important to teach them how to have non-technical skills, also teach them how to handle medical legal situations, how to talk, how to, awareness or predict it's going to happen, mob is going to happen, call for help at that situation. So I think all these soft skills have to be taught, not to be expected to learn on the job, but should be taught properly as a part of simulation, is what I feel at this point. Thank you.
Sure. Thank you so much, Dr. Ekta. Thank you for highlighting that both the content as well as style of education needs to be changed and needs to be incorporated. And I think some of the ways that can be done are the various societies. However, I'm going to now move on to ask a question to Dr. Anju ma'am. She's been on important positions in different societies. I wanted to ask her about the educational resources that these societies provide, and you being the editor-in-chief of the Anesthesia Tutorial of the Week, how do you think these resources can help improve the knowledge and the skill of the practicing clinicians, and particularly those in diverse settings? Over to you, ma'am.
Thank you so much, Dr. Vibha. Thank you for having me. At the outset, would like to thank Dr. Naveen Malhotra, Dr. Bala Venkat sir, Dr. Raj, and the entire stalwarts of CISA and ISA and WFSA here. Indeed, what has been an interesting evening, listening to all stalwarts, and as everybody said, would have loved to keep on listening than speaking. You're right that we need to create a kind of a continuum as we talk about the annual theme of WFSA. It's basically also trying to focus on creating a continuum of training, not only which addresses the formal training during your graduate or your DM years, but also continues into your practice years, as Ekta said about faculty, about practicing physicians. And I think as societies, our role is to first have a kind of identification of gaps in our in the entire continuum of patient care pathway, to see where our gaps are, especially in the longer run as we go into practice across diverse settings, right? And then see how do we plug those gaps. And one of the ways I think ATOTW does, and I believe webinars of ISA and CISA and all other activities are basically trying to kind of bridge that gap by creating a structured environment of learning, right? We are trying to take each of these aspects of the entire patient care continuum into small parts, and then create a micro learning blended modules which help the learners in these era of digital era, I would say, and the AI era, to relate to them and to be able to also, I think we also need a kind of step further to see that the knowledge that we are imparting through these micro learning structured modules that we have are also, we are able to break them into small competencies which can be taught, which can be measured as to how much has been learned, and then of course be practiced into patient care, and then measured the quality and safety of your patient care. So that's the kind of a continuum that the societies across the globe needs to collaborate together to work on each aspect of patient care continuum pathway. And then perhaps, break it into small parts and then continue to teach and evolve it further. That's one, part that I would like to, say that. And then other thing is that I would also like to take an opportunity at this point in time to say that we have at ATOTW taken along this annual theme, and we have started to work on tutorials. And I urge the entire anesthesia community in India, because we have diverse settings and we have all kind of LMICs and HMICs scenarios across our care settings. to come forward to, create not only give us ideas or not only to create tutorials or such kind of modules, micro learning modules or blended modules, but also to, to take it forward and be part of this entire initiative as reviewers, as editors, and play a larger role in the global community. And that is where I think perhaps we really need to go. At the same time, I just want to emphasize, and I'm really happy what Dr. Naveen Malhotra talked about, is creating a kind of a hub and spoke model across the country where you would have centers of excellence, create champions, create training or train the tutors and the trainers and then take them forward. And we really never should forget especially the rural areas, the remote areas of our country. I have realized this ever since I went to Batenda. It's a remote corner of Punjab, a very, never kind of looked at by any of the administrations. And I'm happy that the country is now looking towards such areas and we need to take them along. Otherwise, we would not be indeed moving forward as far as standardized training and structured training is concerned, as Ekta is talking about. I think this is what I have to offer. I believe and I look forward that there would be a structured, standardized, framework under which we would look at, context-sensitive, specific learnings and context-specific micro modules to be built up for patient care pathways. Thank you so much.
Thank you.
Thank you, Dr. Anju, for comprehending how the society should go forward for building the image and educating the people around. And in the same way, IISc is also working with different modules. We are working on webinars, we are working on tutorials, Monday classes, master classes, simulation, and so many things in workshops and conferences. We are working on so many things so that the people from outside, those who are, at a place where the education is not very good, they want to train themselves in newer modalities. So we are establishing all these things. But the thing is, like, when we talk of freelancers, so most of the people, you can say 60 to 65% of anesthesiologists, they are freelancers working in different kind of setups. They may be working in a very good established centers, maybe in the rural area where the resources are very limited. So we have to think about them also. And what is their perspective, what they think about themselves, what they think about ISA, how ISA should help them. There are so many problems these freelancers used to face. So I would like to invite Dr. Shiva Sanmugam to throw some light on this aspect also, where resource limited setting these freelancers work.
Thank you very much, Raju sir. First of all, I thank the team ISA and CISA and Dr. Viba and the entire team for giving me this opportunity. And I thought I am uniquely positioned because I worked as a freelancer and did a medical college practice. Right now, I am working in an institute of national importance. So I have seen the spectrum of all the three sectors that we all of us talking about. So essentially, actually, the freelancing setup is an unique place to expand our role just because there is nobody else there. In that clinic setup or a small scale hospitals, the only physician available is anesthesiologist, and the entire surgical colleagues and the system wanted us to do this job because there is nobody else will be there and nobody else also understand the perioperative the need of the particular patient. So essentially, by default, we are in the ideal position to expand our role. But unfortunately, we are only people, we don't do it. Essentially, because we care multiple areas, we run from one place to the other place, essentially driven by the monetary benefits, a lot of other logistics issues as well. But the system demand us to do that role, but we couldn't able to offer. So now how to overcome this? I think that should start from us only.
Instead of looking at the number, if we can reduce the place and focus on one or two healthcare settings and spend little more quality time. In terms of, as everybody pointed out, if you have a one preoperative visit, as introduce ourselves that I am the anesthesiologist, these are all my plans, these are all the concerns that you have, this is what I am going to do in the intraoperative period. And one postoperative visit will make them understand who we are. And that entire system is looking for it because nobody else also to serve this, no specialist available, there is no advanced costly investigations. So that freelancing setup is the most ideal to expand our role, and the situation is looking for us. It is only we are the people who are not offering to it. And this is the way that we can move towards it. So as the next question goes on, what we can do tomorrow is just to make a personal visit to all the patients that we are dealing with. One preoperative visit, one postoperative visit, an introduction of us, who we are in their care pathway. That will be the biggest step that we can do from now onwards. So with that, actually, my visibility was much better in the freelancing setup than now in Institute of National Importance, because I'm one among the 100 people. But there, every system depends on me. As everybody pointed out, we are in a better position to influence every segment care of the patient if you involve pre-op, intra-op, and post-op. So that is what I can share to every one of you. If this attitude change comes from within us, I think the freelancing has got a bigger role to play to showcase what we can do to our patients. So that's my thoughts on this, Dr.
Wonderful.
Rajiv.
Yeah, thank you, sir. Thank you so much for sharing such a different perspective of freelancer, where you actually can make much more difference probably than people who work in institutions. And I'm sure if there are people who have joined us in the audience, or even this is going to stay as YouTube recording, so even when people log in to listen, this piece of advice is going to be extremely useful. Thank you so much, sir.
Thank you.
While we keep talking about diversity, I'm now going to ask Dr. Shailaja, who is part of the Diversity, Equity, and Inclusion Committee of WFSA. Dr. Shailaja, the workforce is diverse, the workplace is diverse, and how can we still hold on to DEI? Because I believe, and I'm sure even you believe, that this is how we all can move forward together. How can we do that?
Yeah, thank you, Dr. Vibha, for the question. And I thank CISA and ISA for this opportunity to be here. It was wonderful listening to everyone. And I ventured into DEI when I was looking at WFSA committees and all, and I found it quite interesting. And before that, I didn't really have any idea about the DEI committee, all that. This was around some 3 years ago or so. And I understood that it is very important to look at these specifics. Of course, I am into pediatric anesthesia and obstetric anesthesia, simulation, all these things. I love doing them. But then my focus shifted on to DEI, because India, if you look at our country, India is one of the most diverse countries in the world. And our patients have different languages, different cultures, literacy is very variable, socioeconomic status is variable, geography, age, gender, so many access to the healthcare systems, everything is so variable. And we are spread across such a big country, and our needs also. So the one practicing at a rural setup has different educational needs, and the one practicing in an urban setup has an entirely different requirement as such. So sometimes we end up catering more to the urban anesthetist rather than the rural anesthetist, I feel, when I look at the educational initiatives that are happening. So sometimes I don't see any blind nasal intubation training happening. I see fiber optic intubation happening quite too often. And people usually throng to the workshops also for those higher end ones. But think of it, when the fiber optic scope fails, how do you take care of your patient? So all these things are small nuances along the patient pathway that you need to have focus on. And each and everything, the needs of the specific anesthetists, the needs of the patients, the needs of the whole ecosystem of the healthcare. Like, it's not just anesthetist I want to talk about, it's also the system where some things are lacking. Even in higher end corporates also, there are, the systems are lacking. If some of you are working in the corporates, you would really relate to it too. And at the fag end of the thing, on the low resource settings also, there are a lot of deficiencies, yes. But sometimes we think that the people who are at the high end, they are capable of imparting knowledge. But when I look at it, sometimes the low resource setting people have so many different ideas that usually can bring about patient safety quite easily, even when you don't have much of the resources. So they get tuned into it so much that they have a large bank of knowledge which needs to be tapped into, and we need to look into it. And as a society, Indian Society of Anesthesiologists, we need to pull everybody together and see what is required, the needs assessment of all of our people, and how we should train. And even we create modules, webinars and all. So there should be some way of recognizing what they already know, maybe with a questionnaire, and somewhere they would understand that, okay, I think I know this, but I really don't. And then they would go back and actually watch the module. And sometimes they know that they don't know it at all, so they would watch the module and then go ahead with the questionnaire. So something like that probably would actually give exposure to each and everyone what they actually need, rather than putting up specific topics only. But yeah, this is all like my thought process, that's all. I don't know how far it can be put up into practice as such. And thinking of the role diversity, what it means to us is recognizing different needs of our patients, like Dr. Vrushali ma'am was saying, Dr. Shaila Mintra ma'am was saying. So all of you, as you people were saying it, the we should recognize the different needs of our patients and our colleagues also, and our practice environments also, and try to be wholesome and get ourselves to be wholesome with the education, as Dr. Ekta ma'am was saying. So equity also, see, every patient should have access to safe environment, high quality anesthesia care, where every anesthetist has access to the education, the mentorship, the opportunities to grow. Everybody should have. And the growth and all, it differs for each person, it is very different, it is very individual, that kind of growth. And we develop guidelines and all. So wherein we say, let us say we want to use video laryngoscope, but in our country, where is the video laryngoscope at each and every place? So maybe we, even in the guidelines when we are developing them, we should have different pathways wherein you have certain gadgets, you don't have certain gadgets, and create guidelines for each different situations too. Because in a country like India, and also when I go for my vital anesthesia simulation training, I go out of the country and all, I realize that there are many countries far more requiring more and more anesthetists than our country has, and they have much more need of specific trainings and all. So each one has to look into things and streamline things properly, and along the pathway of the patient, you need to grow as an individual, as an anesthetist. You need to grow yourself. Each one should have that inculcated within them, as Shiva sir was also saying. So it is the mindset, and we need to have that particular mindset to grow and to make our patient safe all the time. Yeah, thank you.
So thank you, Dr. Shailaja. So you very well explained the diversity. Means it could be the diversity of the patients, it could be the diversity of the anesthesiologists, diversity of the situations in various kind of operation theaters, even in good operation theaters or in rural operation theaters. So diversity is at every step. So what we have to do is we have to standardize the things so that each and every anesthesiologist working in the field should be feeling comfortable at their workplace. So minimum monitoring standards and everything should be set so that they are also medically also safe. So these are all the things we should think about, and ISA should do much more than what it is doing. So it is not only diversity of this, but also of the workforce also. Many places, a single anesthesiologist is running from one OT to another, particularly in freelancing, while in government setups, there is ample of the anesthesiologists. So workforce is a good amount at some places, at other places it's scarce. So all these things needs to be taken care of while you're seeing that a person who is working around the clock, he should be well taken care of his health, his family, his friend circle, socialization, everything should be there. So what I feel is that in particularly in freelancing, we should go for group practice so that we can be support of each other at the time of emergency, at the time of socializing. If you want to go for a vacation, even then you are comfortable. So now I would like to invite Dr. Murli Thondabhavi to put his views for the workforce and how anesthetists well-being is concerned and how they should go about it.
Thank you, Rajesh sir. Good evening to one and all. I would like to thank the leadership of ISA National, the College of ISA, and of course the WFSA for putting together such a wonderful concept together so that we all learn from each other in one evening. And there's been such an exchange of thoughts in the last 2 hours, which I don't think we can find in many meetings if we attend. So coming to the question, I play the role in the College of ISA as Associate Dean and also in the WFSA in the Workforce Wellbeing Committee, and have been passionate about work-life balance and workforce well-being for more than a decade or so. So talking about the aspect of burnout and this exhaustion, there are plenty of studies which are coming out saying that, yes, anesthesiologists are seeing a higher rate of burnout. There is even a WFSA statement as to why this could happen because of mainly the amount of vigilance that we actually have to give in the operating room environment. But if we look at the theme which we are discussing today, which is anesthesiology along the patient pathway, I think we should label ourselves from being service providers to becoming owners of this pathway. So I think that is the mindset change that we need. Now, why is this mindset going to improve workforce well-being? I would like to just put my point across. We have always been people sitting at the head end, right? There is somebody behind this green screen, who is giving anesthesia, but we don't know who that is. The same thing goes with the patients. We ask any patient who's undergone a surgery, they'll remember the surgeon, but they'll not remember who was the anesthetist. So this is one of the reasons why being providers of very high quality care not being recognized is a reason for burnout. And this, if we address, as all the many other speakers have been talking about, by visiting patients pre-operatively, post-operatively, and meeting them, telling that who we are, it will make a huge difference. Now, taking a small page from what Naveen sir was talking about, as a chronic pain physician, I see the other side of the story, that when patients come back thanking you, and Dr. Naveen was mentioning so nicely that you have the blessings of so many patients, especially when you treat chronic pain, it is a different feeling. As an anesthetist, I know that I'm not being recognized, but as a chronic pain physician, when I sit in my pain clinic, I know that these patients are coming and thanking me. I wish more anesthetists feel this way. I wish more anesthetists meet their patients, see how their blocks are working, how happy the patients are the next day after they have undergone surgery, and have a 5-minute chat about what their life is about, who this patient is, rather than just treating them as a patient or metaphorically a case. I think we should start treating them more as human beings, and in reciprocation, they will treat us as human beings, and this will decrease a lot of stress in our own lives. And the other thing which the owners of the pathway will make a difference is that we'll go from the fire fighting mode to fire prevention mode. So to give you an example, a well done pre-anesthetic checkup 3 weeks in advance will prepare the patient so much well that we will be actually preventing the fire rather than fighting the fire. Now, this again is a big source of stress, a big source of concern for the workforce well-being. So if we are able to kind of play this role along the patient pathway and become owners of the pathway, I think it's going to make a huge difference. So I'm not going to take much of the time, but I would like to call upon everybody here, all the seniors here, that we should actually work together in actually making guidelines, as many people have been mentioning, or some kind of a roadmap as to how, as anesthetists, we can take on these roles, and probably encourage the juniors as well to kind of think about this in multiple ways. We had Dr. Ekta and Dr. Anju Madam talking about various aspects of that. So let us make ourselves a little bit future proof. Let us not just sit inside the OR and just give anesthesia, because we have already made it so safe that people will start replacing us at some point. And the management will start replacing seniors with juniors, which is already happening. So I think the well-being issue will come if we are going to kind of diversify our roles. And this theme is such a wonderful theme. Dr. Viva, thank you very much for initiating this entire thing. So I would like to say one thing, that anesthesiologists in India, please become more visible to your patients. And from the workforce well-being perspective, I think it will make a difference. Thank you.
Sure. Thank you. Thank you so much, Dr. Murli. Becoming the owners of pathway, becoming more visible. And I like the perspective that you gave, that, by taking up more responsibilities, it is, one may think that, is it actually going to decrease my well-being because I'm overburdening myself? But actually the opportunities that we get, whether it's in pre-op anesthesia evaluation and connecting with the family, or whether it is chronic pain, like you mentioned, I think there are more rewards to it, which will help us improve our well-being. So thank you so much for bringing that out. Well, whenever we talk, so we spoke a lot about how to go about including what can be done and the educational resources. Only after Dr. Murli told me, I realized that we've crossed more than 2 hours. So however, I might hate to say that, but I would request the future panelists to be very brief and crisp in their answers. So for Bhimeshwar sir, I'm going to ask that you've been in governance roles, sir, before, and the societies, professional societies do play a very important role in safeguarding us whenever we want to take up these extra roles beyond the traditional roles that have been assigned to us. So how do you think these professional bodies, and ISA and WFSA is typically what we are discussing, how can these bodies help us? Over to you, sir. You're muted, sir. You're muted.
Yeah. Thank you, Dr. Vibha, for this wonderful webinar that you are conducting. And without wasting much time, I would like to straight away go into this role of what the professional societies, that is the ISA and the WFSA, role in actually doing it, and the medical legal aspects as well. I would like to say something about the medical legal aspects. Actually, the role of anesthesiologists, like everybody was saying, is not only confined to the operating room, but is spread in several places. In several places, like the ICUs, like the pain specialists, and many other things. But I must tell you here one thing. Though we are competent here, are we really qualified? We need to take on that, because what happens is, when it comes to the legal issues, here I beg to differ from many of our colleagues, but when it comes to legal issues, are you really qualified or are you really competent? Yes, I'm competent, but am I qualified? These are the two things which need to be answered whenever you face a court of law. These are the things, and this is where exactly the role of the Indian Society of Anesthesiologists and the role of the WFSA comes into play. They make a very big difference in this sort of things, where the gap between the qualification, the competence, and the medical legal aspects has to be shortened. This is one thing, the ambiguity has to be definitely reduced, the medical legal ambiguity. This can be done in 3 ways. One is by defining, second is by legitimizing, and third is by recognizing. These professional bodies of ours, that is ISA, WFSA, has to first define what we are, then then legitimize what we are doing, and then subsequently recognize what we are actually doing. And once this recognition comes, we need to strengthen this. Strengthening is by professional training and many other things. But perhaps the one thing which is lingering behind every anesthesiologist is the medical legal aspects. What can happen to me if such and such a thing happens and all? Actually, we need not have to worry about what happens in medical legal things, provided we are doing the set protocols, what we need to do, and are we doing it the way we need to do. For this, again, the professional bodies like the Indian Society of Anesthesiologists or WFSA or the universities, they have set certain protocols, they have set certain SOPs, they have set certain guidelines. Only thing is, are we following these guidelines? These needs to be really taken into consideration. Once these are taken into consideration, and if you are following these guidelines set by our societies or the university or the WFSA, we need not actually worry at all. In addition to this, the other non-technical skills like communication, ethics, and all these also are to be trained so that an anesthetist becomes full-fledged to deal with any situation that he comes across. These are the main things. And what I can say is the professional competence comes from clinical competence. Okay, professional confidence, sorry. And then the medical legal confidence comes from clarity. When we have a clarity about what we are doing, we need not have to worry about anything at all. Here, I would like to tell one thing about the competence and qualification, as I had already told you once. I am a qualified anesthesiologist, but am I competent to give a block? So, like, supposing I had been a professor in Sarojini Devi Eye Hospital, where more than the anesthesiologists, the ophthalmologists were giving up wonderful blocks, the peribulbar and the retrobulbar blocks. So, is the ophthalmologist really qualified? No. The answer is no, legally. But he gives a better block than the anesthesiologist. This is one thing we need to take into consideration. Okay, that is why an anesthesiologist is always kept as a standby for all ophthalmic cases because of the legal aspects of it. Second thing is, what I wanted to say is, I told you about this thing. And one closing remark, what I would like to say, maybe after 10, 20 years and so many years of into anesthesia, I would like to say that there are no good anesthetists or bad anesthetists. There are only lucky or unlucky anesthetists. You document, you record everything, you do as per the procedures, you are a lucky anesthetist. Thank you so much.
Thank you, sir.
Thank you, Dr. Bimishar, for throwing the light on the medical legal aspects. But yes, it's very much need of the hour that anesthesiologists, they should learn about the medical legal aspects in all the sense, because they are dealing with the patient in the critical care, they are dealing with the patient in the operation theater, very risky patients, high risk patients. So they should know about what all they can do. Nowadays, it's very common, the assault on doctors. So if you know the things, how to communicate with the patients, how to communicate with the attendants, then it is really, it's a big boon for you. And you should be able to communicate with them in a manner so that they understand. Because, when you say it's a high risk patient, so attendants are always jittery. They always ask कि high risk है लेकिन patient ठीक तो हो जाएगा ना, बच तो जाएगा ना. So they always has a hope. Despite being high risk, they want their patient to be safe. So we should know how to keep our patients safe. and how we should communicate and what kind of consent we should take, which is very, very important. Consent is very, very important in our subject, and we should learn all these things about it. So after talking about all the aspects, maternal, well-being, pediatric, and so many other things, now the thing comes, only these things can lead the path to a better anesthesiologist, or something more is required than that. So here comes, after education and courses, do we really need to enter the research area, to enter the publishing area? So I would like to invite Dr. Bala Bhaskar to emphasize that whether the research and papers, they are equally important, or only running from one OT to another OT, or going to different aspects like pain physician, like critical care, and so many others, that only that is important.
Thank you very much, Dr. Rajiv Gupta. Nice to be here among the ISA colleagues here, along with our WFSA, activists now, if I can call it so. So, President IS National, Chairman Academic Committee, Dr. Bala Venkat, then Dr. Uma Maheshwar Rao and Dr. Srinivaslu, the rest are GC members and other colleagues here. So, if I cross 3 minutes, Dr. Vibhavari can stop me also, right? So probably I'm the penultimate speaker. So it was so nice to hear everybody that what we should be doing in terms of planning, then actually bringing it to practice and achieving certain goals in terms of the patient's pathway throughout the type of procedure or the surgery he or she undergoes. Planning apart, one of the major hindrances, especially in the low-income countries and low-middle-income countries, because we are part of WFSA. WFSA is more inclined to support the improvement in anesthesia services in this set of conditions. What is seriously lacking is the data, right? Even within our country. So all of us have to take the blame and also initiate measures to see that we improve upon the data within our own country related to anesthesia and the perioperative period. We are not able to say even now, yes, how many of our patients, very simple. We always look into, again, the Western literature that the instance or prevalence or something is like this in Europe and other things. So we don't have hard data. To get a hard data, definitely we should have some sort of research taken up. Okay, there have been some sporadic research related to data collection at the level of individual institutions, individual investigators, but nothing has is being consolidated as a national data bank. So this is one of the reasons that we must conduct research. It's not that, again, we do hi-fi research. Majority of these data could be obtained basically in the form of simple observational studies. Okay? It could be a tertiary care center. It could be even a private practice. Dr. Shiva Shanmugam was speaking about the problems in the private practice. So even now, there are many private practice setups where there is a lot of data, but we have not been able to mobilize it. So as we think about the pathway, so it could be, as we know, from the preoperative area to the intra-op and the post-op. And post-op need not be restricted to the 5 days, 3 days, or the daycare procedures. It can even be a long-term thing in terms of the patient's chronic pain or some other complaints related to anesthesia, the backache after spinal anesthesia. So these are some of the things which are to be covered. So if we want to systematically split it up, for example, we have trauma patients. Okay, we have got emergency medicine. So how many of us know what is the, for example, the available facilities and our protocols? What is the time between the event and it is brought to the hospital? So that is one area which even at this point of time we don't have. Secondly, for example, even is there a protocol in terms of transfer between the hospitals and within from primary care center to a tertiary care center? How many of these patients receive analgesia while being transported? Yes, because it is our role to provide analgesia to the patients, right? And resuscitation, of course, we have got some setup now. We are all part of ILCOR. We have got the IRCF, of which ISA is a major stakeholder. We are trying to get some data, but we have not been able to go forward in many of the other areas. And even in terms of, for example, inpatients, I think we spoke about. Because I have taken care of at least 2 guidelines on behalf of the Indian Society of Anaesthesiologists in terms of preoperative fasting and preoperative investigations, right? So do we have some data that how well and are the patients fasted in the preoperative period? How much are they adhering to the preoperative fasting guidelines? We still don't have data despite our own guidelines being there, which one of our speakers were speaking about, that we should have our own guidelines. We have it, but we have problem in implementation. Then we have a guideline about the preoperative investigations. Many of us have read it, but many of our colleagues have also not gone through the whole system. When we speak ourselves to be perioperative physicians, right, we must also be knowing about what the investigations have to be advised in the preoperative period. Okay, and as our secretary was speaking about, do we know about how many of our patients present with anemia? How many of them present with diabetes in the preoperative period, right? Hypertension. So these are comorbids which are increasing across the board in India, and we don't have a data. And we attend to the patients every day, right? So this is another thing which is very important. Then anxiety status, yes, we don't treat anxiety, pre-op anxiety majority of the times, right? Definitely, I think many of our colleagues would agree that one field is anxiety and not just a pain relief for the patient. So that has not been attended to. Then, of course, we do speak about prehabilitation with respect to the ERAs and other protocols, oncosurgeries nowadays, but it has got a scope in different subspecialties also, which can be taken up as a routine. So this is another area of research which can be taken up.
Sure,
Observation studies, so which is very easy for us to do. It could be a NORA situation. Many people were speaking about the NORA also. Very simple. What was the way, what type of sedation was provided, what was the type of sedative which was given, how many of the patients needed some general anesthesia, how many of them needed airway management, how many were, there was some urgent requirement of airway management, were there any complications, catastrophes?
Sure.
These are also being some certain scope is available in this area. And to finally, just to a few seconds, even post-discharge, we have to follow the patient, like for a week, for a month, or even beyond 2 to 3 months, because it is our duty, especially because we speak about chronic pain after surgery. So that is also very important. Whether we have a protocol, we have got guidelines, whether we have got some communication system to get into touch with the patients after the discharge. So these are some of the things which I am able to convey within the 2 to 3 minutes that is allotted. Definitely, there is a great scope. So let us all strive towards having these small things. And in terms of design of this study, they are very simple. We can have retrospective studies, simple prospective observation studies. We can have audits done for the in a hospital, okay, before and after studies. So this will all help us in giving not just the data, but will also give an overall picture of the scenario where we speak about the patient pathway, our role in the preoperative period, not just intraop period, and the postoperative period and NORA. So thank you very much for the opportunity, Dr. Vibari. Thank you very much.
Thank you, sir. Thank you for highlighting that research, not just in the areas the questions to be included only in the anesthesia part, but if we expand our research along the patient pathway, I think the role keeps on evolving much better, and auditing is one very good way of doing things. And now I'm going to ask Dr. Rakesh Garg, sir. I might want to do this research, like Balavaskar sir has just said, but will the journals, the publishing houses of these journals want to support this kind of research? And what do you think, how these can play a role in helping us expand beyond our traditional confines?
Absolutely, and thank you, the leadership of ISA, the college, and the WFSA for this interesting talk with the theme of WFSA. As Balabhaskar sir mentioned, if you remember, Dr. Vibha, some time back, the journals were considered to be a repository of research by researchers. They will do a research, conclude something, drug A is better than drug B, and full stop. But if you see the last 2 decades, societies like ISA, WFSA, ILCOR, they are using this research and they are translating into in some form that they become clinical practice changing. It is maybe in the form of a SOP or a document or a policy or a guideline. And these are what wherein the journals provide a platform, a solid platform of a robust research that they can easily translate into policy. I'll tell you one simple example how this is done. You remember when our kids get diarrhea, we used to give them zinc containing solutions. It came from India, and this is internationally accepted as one of the treatment of the ORS solution, which is being given to people across the world. A small research, but it has changed into a policy matter, and it has changed the infant mortality rate across the world. So this type of changes which has happened, I think this is what journal is propagating. It should not remain a journal perspective as a matter of research. If you remember, evidence-based medicine has 3 pillars. Yes, research is one. But what about 2 pillars? We always talk of EBM. It is patient values and clinical expertise. Now, herein we have been talking, and the previous speakers have very nicely mentioned that patient values are also a part of evidence-based medicine. If we anesthesiologists try emphasizing those research to the public, it becomes important. So now the journals are propagating, just not publishing it, but they are coming with novel ideas. Why not to use digital media? Remember like starting from various journals, and I'm proud to say that Indian Journal of Anesthesia also took initiatives in the form of infographics, podcast, videocast, and other things which has come into the social media. Now, when these goes into social media by the journal, the public gets a reach of it, that the person behind is just not a person behind the screen, but it's the person who comes into the visibility of the general public. We always talk about why should not we create awareness of anesthesia and anesthesiologists among public. This is what journal has taken this initiative across the world to bring it, that this information or this thing had changed because they have been emphasized. So this multimedia dissemination is important aspect which all journals should do, so that the research, the hard work of researchers goes into the public and they started doing it. Having said that, I said patient values. Another point that we should be a little considered about it. If you remember, we used to research NRS score decreased by this, the opiate consumptions are decreased by this much of milligram or something. Now we have to convert those soft outcome parameters to something called patient-centric outcomes. And by this measure, what we call as the patient pathway, I think now we have to look for patient pathway centered outcomes that we should be looking for, so that we can improve the outcomes. And this is what the journal are supporting all the aspects. So I can easily say that the journal role for research would be, when we say think globally, improve locally, but publish widely, so that we can have more reach and we can follow those things. So I'll add another term, publish widely. So I'll urge each one of people who are attending, whatever you're doing it, I think Indians and the people across are doing enormous amount of work. Just collect your data and publish it. I think this is what we need for the day.
Thank you.
Thank you, Dr. Rakesh, for nicely elaborating why publishing is important. वो एक कहावत है, जंगल में मोर नाचा किसने देखा. So whatever you are doing, if it is not published, it is not shown to the public, it is not propagated to your colleagues, how they will know what is going on in India, worldwide also. So now our publications are to the extent that even the global people, they recognize us that we are doing very good work. And that is why it is very much required that whatever work we are doing, whatever research we are doing, we need to publish it in the journals, in the national and international journals also. So after listening to the galaxy of visionaries, now I would like to invite Dr. Balavenkat sir. So what is your take after listening to so many people, how to go how to go forward with these talks and with these things which are told by so many people.
Rajiv sir, I think Bala sir is not there right now. I'm going to request Dr. Swagata to tell us how to take this forward. Dr. Swagata? Hello. Please unmute yourself.
Yeah, hi. Thank you, Dr. Vibha. And I realize I'm filling in very big shoes in the program today. It's been wonderful listening to the stalwarts of the Indian anesthesiology community. Thanks, Dr. Rajiv and yourself for this program. There's nothing much more left to say. And if we were to identify the single biggest opportunity that Indian anesthesiologists have today, perhaps, like all of us have said, it is time to move forward from a procedure centered specialist to becoming a patient centered perioperative physician. We have heard exactly this from the speakers about maternal care, pediatrics, critical care, pain medicine, education, governance, research, and publishing. Towards the end, Dr. Bala Venkat and Dr. Bala Bhaskar and spoke about research, which is certainly important. But I think the next challenge, which will also get us more published, will be the implementation. So we will generate the evidence. We'll take the evidence from the bench to from the bed to the bench side, but we also have to come back in a continuous cycle. Clinical experience should identify new questions for research, and then you implement it for patient benefit. That is what will make us recognized. And again, there is immense opportunity to do this in all the three areas we identified, in all the three practice environments. Like other speakers said, the medical colleges can generate the evidence, train the future workforce, and evaluate new models of care. The corporate hospitals, we anesthesiologists along the pathway can pioneer the multidisciplinary pathways, quality improvement programs, and look at digital innovations, which would be something they can do. And private practitioners who will care for a larger proportion of our patients will be essential in ensuring that this evidence-based practice that is being generated will actually reach routine clinical care. And it's only with that that real transformation will occur if all of us, like you said very nicely, move forward in the same direction. And so in the end, it was a wonderful program. We need not focus on creating any more roles for anesthesiologists, but maybe on creating a greater value for patients, because that is where our true calling lies. And that's where we will get the recognition and avoid the burnout, like Dr. Murali was saying so nicely.
Thank you. Thank you so much. Such lovely summarizing, Dr. Swagata. And as we come to the fag end of this webinar, I'm just going to ask the panelists who are present here to just give one liner, just one line that you think is the take home message for the audience out here. And I'm going to go the way I can see them on the screen. So Dr. Shailaja, can you go in first? Just one line as the take home from you.
Yeah. Keep in mind the diversity, equity, and try to be inclusive in your approach to each and every patient, and along with your whole team. Then you get there to good patient safety.
Staying so true to your role in WFSA. May I request Bhimeshwar, sir? Okay.
Yeah, whatever you do, you need to document. That's one thing which I want to say.
Sure. Thank you, sir. Thank you. Anju, ma'am.
So just for the entire future generation, I believe as leaders, we need to be role models, modeling what we all have taught today, along the entire continuum of care for the patient. And of course, as sir said, document, publish, and then go back and audit and see how well you implemented it.
Thank you. Thank you so much. Dr. Ekta.
Yeah, so For me, education, basically learning is a continuum process. It has to go along various stages in your life and be innovative in your education.
Well said. Thank you, Dr. Geeta.
So, hi. I think we have to have a patient-centric approach, a collaborative approach, take the obstetricians on board and the rest of the members of the team, but ultimately focus on the patient at every stage of her, you know, childbirth, before and after.
Childbirth comes in. Thank you.
Yeah.
Yeah, Dr. Neha.
Yeah, just to summarize in one line, I would stress on upheld the standards of perioperative care wherever or whichever setup you are, and keep your patients safe along with yourself also safe with due monitoring, feedback, and record keeping, and so many things. So, safety is not for only our patients, we are all stressing on. Keep yourself also safe by following the protocols and keeping your records well. Thank you so much.
Thank you. Naveen, sir.
Be honest, sincere, work very hard, have good intention, and become chronic pain physician.
Sure, we got your point. Thank you. Dr. Sheila, ma'am.
Yeah, hi. So I would say we have to look at ourselves beyond just perioperative physicians to looking at caregivers of critically ill patients, not necessarily post-operative care patients, and keeping patient safety and caring for patients at the center of our what we do.
Yeah, thank you. Very thoughtful. Dr. Balabhaskar.
Yeah. So whatever we plan, whatever you have today discussed about the implementation, and then think about the nation trying to influence the government across the country and in the rest of the world. We need hard data and validated data in the form of a research. So that's one of the things which must come to your mind when we go forward.
Sure. Thank you, sir. Dr. Murli.
I don't think I have much to add except the fact that you should look after yourselves and look after your team. And as I said, owners of the pathway. That's what I would say.
Thank you. Dr. Rakesh. I think he's outside. Dr. Shivishanmugam, sir.
Yeah, I mean, meet all your patient at least once in the preoperative period and introduce yourself, and make one visit in the postoperative and just ask them how they felt the entire experience. That will go a long way.
Sure. Thank you. Dr. Swagata.
Oh, okay. So I think again I'd sum up. Just every time ask yourself, how can you improve the patient's journey beyond the operating room? And then you will be able to, I think, do everything that all the participants have said so nicely.
Thank you.
What
Thank you,
about you,
everyone.
Vibha?
Well, I think my message is just keep collaborating. And that's, I think, what the theme was today. And with all of you distinguished panelists joining in, sharing your views, I think we are trying to connect, collaborate, and trying to make sure that we improve the patient safety, quality, care, as well as our well-being. So thank you so much, everyone, for joining here today. I'm going to hand over now to Dr. Srinivaslu, sir.
Yeah.
It's been a long evening, sir.
Yeah. Thank you, everybody. I particularly thank the leadership and office of ISA National and College of ISA coming out with this wonderful concept of bringing all the galaxy of the speakers who are connected with WFSA and conducting this WFSA presidential theme webinar. And I think this webinar will take us forward in meeting the objectives just discussed, and hope this will be a fruitful work. And I thank Dr. Vibhavari Nayak and Dr. Rajiv Gupta for coordinating and moderating the session. And I thank all the panelists for their input. And so in the end, the one-liners. And thank you one and all. And I thank all our members, esteemed ISA members who have joined for this program. Thank you one and all. Long live ISA.
Thank you.
Thank you, sir. Thank you, Dr. Vibha.
Bye.
Good
Yeah,
night.
thank you. Bye-bye.
Thank you very much,
Thank
everyone.
Good night,
you,
everyone.
everyone, for joining in. Thank you.
Thank
Good
you.
night.
Thank you.
Good night.
Thank
Good
you.
night.
Good night.
Good
Bye-bye.
night.
Good night.